This conference will now be recorded.
Good evening. It's John Antonucci. It's August 13th. AnCan's high-risk metastatic advanced prostate cancer discussion group. We're going to start off by thanking some of our sponsors: Bayer, J&J, Myriad Genetics and Telix, Blue Earth and Foundation Medicine. I guess we should add Boston Gene because they paid for Rick's supper the other night. And I'm not sure of the status of Novartis at the present time. Are they still a sponsor for
Yeah,
us?
Novartis is definitely with us.
They definitely are. Okay. So welcome, everybody. Usually we start with the new guys, but we don't have any tonight. So I'm just going to go right into our list. First, I got Mark V.
I just want to give a real quick update from last week when I was feeling not very good, that I was so tired and so exhausted, and I was blaming it on the Xtandi that I was sure had just worn me way down. And what a relief when I tested positive for COVID.
Oh,
It was good news in your
It was
case.
really good news, and I'm doing fine with the COVID, but it was. Yes, I'd much rather have COVID than have all those drugs knocking me down. Anyways, I'm doing well, thank you.
It shows you what a weird world we are living in this prostate cancer world, that we're glad to have COVID.
Well, you
oh my God.
hope it's not long COVID.
Yeah,
Yeah.
you look like
How
you're
are you?
feeling okay.
Yeah. How are you feeling now, Mark?
I'm still pretty tired. I mean, I haven't got all the way through the COVID yet, but I'm doing better.
Probably nearly a year since you had a booster shot, I assume.
Yep.
Yeah, same with most of us. There probably will be a new one out this fall.
Yeah,
They're
that's what I heard.
they're fighting over whether to use the old method or the new method. All right. Well, I hope you feel better soon. I guess you will in a couple of days. From the look of you, you're going to have a mild case. How many days since your test?
Saturday.
Okay, 2 days. Okay.
Has anyone else in the group tested positive for COVID in this summer go around that seems to be nailing a lot of people? Anyone else gotten nailed? Oh, David H.
Yeah, we were on vacation. What a way to ruin a vacation.
Uh,
How are you now?
Oh, I'm fine. It was very mild. My wife got it a little worse. She was the typhoid Mary, and my son, real vital, strong 30-year-old, he got it worst of all. So you just don't know.
oh,
I don't know if May counts, but I got it in May in California.
oh. Mild case or?
No, it was my first time, and it set me back about 3 weeks.
Oh, geez.
Oh, wow.
I
And
am still waiting
I'd
for my
had
first time.
Paxlovid.
You what?
I'd had that Paxlovid,
Oh, you
but
did?
I rebounded from it. About 20% of those who take it rebound.
Oh.
What do you mean by rebound? You mean you got it again?
It comes back. I don't think you get another one, but it immediately helped the symptoms reduce, and then as soon as I finished taking the drug, it came roaring back.
Okay. Looks like Looks like Dr. Jeff knows a little bit about this.
Does he have his hand up or he's just nodding?
No, I could see him nodding in agreement as they were
Yeah.
as people were talking.
Okay, is that it then, Mark? Okay. Thomas, can you unmute and tell us what you have in mind?
Yeah, okay, I'm on now. Yeah, I'm doing well, and I don't want to get into too many details about my personal situation, but I think I'm pretty good on my diet, my supplements, my exercise. I'm working on that all the time, and I just started, and of course, I'm supposed to be putting on some weight, some muscle mass, not just fat and things
Yeah.
like that. Um, so anyway, I monitor that. But here's my question. Um, okay, so I've got my testosterone cut down to extremely low, which is good because my PSA is down undetectable, below 0.05. Wonderful. But when I'm in the gym and I want to gain some muscle mass. Now I've done a little bit of research, just looking around. All of a sudden, it looks like I'm in a situation where I can't do that. I can't gain any muscle mass because of my testosterone being down so low. And I'm just wondering if, is this one of these futile efforts, just go in there pumping iron, and trying to gain, and I think I want a modest increase of, I weigh about 160. I'd like to gain 5 pounds, 1 pound would be great of muscle mass, trying to build up some strength. Is there anything that anybody can say about, this kind of a situation with low testosterone and trying to build up muscle mass?
Well, the answer to that is kind of a yes and no answer. I also thought that it's impossible to have muscle hypertrophy in the absence of heat, and that the best we could do was to keep the muscle atrophy from happening. So I asked this question of Richard Wasserson, who is the guy that wrote the book on androgen deprivation therapy. And he told stories about several people that he knew that while on androgen deprivation therapy, they became splendid athletes and competitive athletes. He felt that it is possible to gain in strength and athletic ability instead of simply not losing. Now, if he's right, then your hard work at the gym will pay off and you'll gain your 5 pounds, albeit more slowly than usual. But even if he's wrong, it's still worth you doing that as much as you possibly can in order to keep from losing any muscle mass. But let me open this up because almost all of us have fought against this problem. Guys?
And I'll pipe in here. I agree with everything you just said, or everything Richard Wassersook said. Um, I think it depends, like with everything with cancer therapy, it depends on the individual. Some individuals will be able to put on muscle mass if they try hard enough. Others won't be so fortunate. But Thomas, you certainly can't just dabble in the exercise. If you want to add muscle mass, you've really got to go for it in a big way. Get your cardiovascular fitness down and lift weights and do it at least 3 times a week. Uh, Otherwise, you probably will not put on any weight or any muscle mass.
Yeah. Okay. I hear you. And I'm in the gym. I go to the gym 3 times a week, and I spend about 2.5 hours each time I go in there. You know, doing the machines, some free weights, aerobics on the treadmill, and that sort of thing. You know. And I mean, I don't know. Maybe that's dabbling in it, and so I'm not sure. I was thinking of maybe getting. Uh, going to OHSU maybe and getting somebody a physical trainer to review my activity, my workouts, and things like this, to maybe give me the point of view of somebody who deals with cancer patients and can make my workout more efficient for gaining weight for my particular circumstance.
Yeah. So, Thomas, let me chime in here because I can I can provide my own peer experience. Um, I started on my hormone therapy in the low 150s, and I was in very good shape. Um, I did aerobic exercise pretty much every day, and I lifted weights 3 times a week. Now, I still put on a lot of weight. I got up to about 169, I think was the highest I ever got to. I definitely gained muscle mass. I was lifting more than I've ever lifted before and since because I hate weights and I'd stopped lifting religiously when I came off my hormone therapy. But from my own personal experience, I know that you can gain. The issue is you have to do it the right way. 3 times a week lifting weights is probably very good. In terms of getting instruction, um, definitely check with the resources at OHSU and please do let me know. For reasons I don't want to disclose at this juncture, I have a particular interest in knowing what the outcome at OHSU is. And the other place is to look on the American College of Sports Medicine. And in a minute, I should be able to put a link in the chat window for you and look at their list of cancer trainers because they offer a cancer certification for their trainers and see if there's anybody in your area and maybe set up a couple of sessions with them. You know, it won't be free. OHSU, it'll probably be free. The other thing is to OHSU will have a dietitian, so you can also talk to the dietitian, and they may give you some help. I mean, we for the longest time, way before we started AnCan, I was trying to innovate an exercise program in every cancer center. We got it into UCSF, and that's about as far as we got for exactly the reason that you are asking. Exercise should be integrated into prostate cancer, all cancer treatment, but especially prostate cancer treatment, and they should be helping you to build the right program. There is a program at UCSF that doesn't help you very much. But we have a couple of hands up, Dr. John.
Jeff?
Yeah, so most centers that are worth anything have a Department of Integrative Medicine, and they often provide advice and programs on exercise. Um, so you could consult and ask them, do you have a Department of Integrative Medicine? And then make contact with them. A lot of these departments do online exercises. I know that. Some are free, some are nominal fees. Um, they do things like Tai Chi, uh, as well as conventional. But I would ask if there's an integrative medicine department where you are.
Okay, I can do that.
Thank you. And Richard?
Hi. There is a machine at Walter Reed Bethesda called an in-body analysis machine. And basically it looks like a scale with some metal foot pads and you hold a couple of things in your hand. And what it does is give a very detailed analysis. I know you can't read it, but this is just uh, uh, what they print out. And if you use the same machine and the same identification, they develop a body composition history. And since I've started hitting exercise pretty hard in June, my body fat has gone down 4%. My skeletal muscle mass has gone up 4 pounds. It's a wonderfully detailed analysis of body fat, muscle mass, uh, extracellular water, intercellular water. You get a very good picture of your physiologic condition. It's called in-body test. And this is at the nutritional facility at Bethesda. So wherever you're going, I would look at the nutritional facilities and ask if they have something like that.
Sounds good. I'd also add to Rick's recommendation that the American Council on Exercise, which certifies personal trainers, has a little subspecialty in cancer as well. So you could try that website too. Mark Valens, your hand is.
My wife and I were part of a trial at OHSU showing how important exercise is. I'm trying to remember the name of the doctor. I'll come up with it and I can send it to Rick or somebody. But they do have a program and they do have a list of trainers. But this doctor is really interested in how important the exercise is. The study we were in showed that it was if a couple like my wife and I exercised together, they did even better than if they just exercised by themselves.
Yeah. Well, Mark, we've known that for years. I mean, back in 2008, when I set up this program at UCSF, we really wanted to create a buddy register, so that if you got on the program, you could be identified with a buddy and you could exercise with that buddy. The problem was HIPAA, and so they at UCSF would not sponsor a buddy register. And ever since, I've always wanted to take MetaFit to another level. I'll put the MetaFit link in the chat in a second. And if we ever could take it to another level, it would absolutely include a match-up buddy service, so that people could exercise. It's so much easier to exercise together than on your own.
Harry, you have your hand up.
Yeah, I don't recall where I read this, but there's a form of exercise that's supposed to be really more beneficial for people in our situation. It's like a resistance exercise that they're really short duration, like 20, 30-minute workouts. And I was doing it for a while. There's a chain where I live that does that type of exercise. It's called the Exercise Coach. You can maybe look it up. I don't know if they're nationwide, and I'm not necessarily promoting them, but their website might have more explanation as to that type of training. They have special machines and things like that high intensity resistance training. That website's really hard. So, might be something.
Thank you. And Harry, while I got you, did you want to bring up anything on your own situation tonight?
Oh, no, thank you.
Okay. Jeff, I'm going to get to you next, but first I want to check in with a guy that came in a little later and might be new, Keith Lawrence. Hi, Keith.
Hi, how are you guys doing? Apologies for being late. I was actually getting a treatment.
Oh, are you a new guy to this group or no?
I am a new guy.
Oh, okay. Very good. Who sent you to us?
I'm trying to remember now. I've been watching the YouTube videos for probably about 4 or 5 months, and
Oh,
got the courage up to join today. So
so you know all these guys. Well, Keith, we usually give new guys a little extra time and get some of their background. If you're comfortable with that, I'll get to you and we'll do that. If you're not and would rather just watch, that's okay too. Do you want me to get to you and get some background?
sure, I'm happy to share.
Okay. While I'm on a roll, I'm going to hit a couple of the regulars and then I'm going to get back to you with plenty of time to get your background, okay? And speaking of regulars, Jeff,
Yeah, I just wanted to follow up on the Orgovix hot flash thing. I am not getting hot flashes from Orgovix, but I get warm feelings occasionally. And I'll go 3 or 4 days without them, and I may have one or two in a day, and I just feel warm. And it doesn't lead to a hot flash. It's just sort of strange, but definitely do similar to what hot flashes are, but just warm instead of hot.
hmm, you think, how old are you? Could you remind me?
76.
And do you know what your testosterone level was like when you started the whole thing off?
Oh, it was over 500 and something.
Oh, so it was quite high. I know that older guys have less hot flashes, and guys that started out with lower T levels have less. So, so I don't know if it's Orgovix or you're the same
Well,
age as all the rest of us. And
when I was on Lupron, 9 months ago before starting Orgovix, I was still getting hot flashes.
oh, the full deals, you mean, not these
Yeah,
warm?
I was on Depo-Provera, so I wasn't getting them continuously,
Mm,
but I was still
yeah.
getting them. And
Okay.
the Orgovix seems to just have stopped
Mm,
anything but this warm feeling. I went like 4 days last week, nothing. And I've had a couple since Friday, but that's it.
mm. Probably global warming instead of Orgovix.
It's definitely not normal. I'd start feeling warm, and it's
Hmm.
So,
it doesn't reach hot.
Jeff, I have to say, I want to take you back to the immense, horrendous issues you had with hot flashes
Oh yeah.
and all of the different things you tried, from drinking ice glasses of water and the watch and the this and the that. I mean, you were Mr. Hot Flash. So when you get one of these warm flushes rather than a hot flash, just think how much better it feels than when you first came to us and how it drove you nuts.
Oh really? It was so bad. Oh.
See what I mean about Rick's memory and his note cards and all that?
Well, but Jeff was Mr. Hot Flash, and every week he'd come on with it, and then he'd have another hot flash, and we couldn't do any. I think we had the breakthrough with the Ember watch. That was really the first thing that gave you any
No,
relief, wasn't it?
the Depo-Provera really
Oh, the
did.
Depo-Provera. That's
Yeah,
right.
but,
Yeah.
but when I went on Zytiga, they came back, and then the watch, then the wave definitely made a difference. And in fact, I was getting these at night. I'd wake up with the bed all wet under me, and the wave device for Ember that stopped that completely.
Well, it does raise one little thing, which might be worth a discussion with Dr. Andrea. Maybe you should think about monotherapy Darrow.
Yeah, I've asked her about that. She's not too hot on the idea. I think the BRCA2 is an issue there.
Are you germline? I can't. You are, aren't you?
No, no,
Oh no, you're
I'm
not. You're
genetic.
somatic. Well, a
Yeah,
couple of things. One
I
is you
don't,
may.
wait a minute. Well, I'm genetic. It's genetic. It's
Yeah,
not
you are
somatic.
germline. Yeah, you
Yeah,
are
no,
germline.
I am germline.
Um, yeah, that could be a factor. That could be a factor.
Yeah,
But
it's
the two doctors that she will recognize immediately who are working with monotherapy, Dr. O with Len and other
yeah,
patients,
yeah.
and Dr. Shmulowitz in Chicago.
Chicago. Yeah.
Jeff, have you ever been on a PARP inhibitor?
I remember I was on one for about 5 or 6 days before I went back to I went to darolutamide and I was having nightmares every single night, just weird nightmares. And you in fact looked it up and you said you saw that nightmares was one of the side effects of PARP inhibitors. But boy, it was bad. And because when I went off Zytiga, Andrea Harstark told me I should go to PARP inhibitor. And after 5 days of that, I said to her, look, this doesn't make sense. I can go to a PARP after I've gone to darolutamide. Better I go to darolutamide first and then to the PARP. And she agreed. And that I'm now 9 months as of today, this morning, 9 months undetectable.
And
So
if the time ever does come to go back on a PARP inhibitor, remember there's plenty of other ones.
yeah, well, there's multiple PARP inhibitors, you mean?
Yeah,
Yeah. Yeah, there's one of the newer ones seems to be more effective. I don't remember. I started with an R, I think. R something cab.
Rucaparib.
Yeah, Rucap.
Rucaparib.
Yeah, that would seem to be more effective. They were saying, but who knows?
Harry is posting some further information on that weight training for people like us. He's using the name Superslow, and it takes me back to when I used to do weights, and we used to do these very slow sets, and they were absolute killers. And I think they were very good, especially slow eccentric uh, weightlifting for building up strength. Um, okay, let me get to the new guy then. We're going to take a time out and get to Keith. Keith, where do you live?
I live in Ventura, California,
And how old are you?
60-year-old,
60. And
60.
when were you diagnosed?
I was diagnosed in March of 2023 via an orthopedics path. I had extreme body pain, mostly in my left leg, and I went to an orthopedics, and he had the wise choice to send me off to a CAT scan where they discovered, I hate this word, but it's the word that they keep using, innumerable bone metastases. So I am head to toe bone mets. And when I got my first PSA, it was 1,440.
Okay. And 1,140. Did you have other kind of scans besides the CT scan, like PET scans or any of that?
Did not, strangely enough, have a PET scan or a PSMA PET scan, which I've had two since. But I did have a total body bone scan,
Okay. And
and
that's where you get scattered all over the place, and that's
yeah, and literally from the top of my skull down below my knees, and ribs and heavy spinal um, inclusion, and of course pelvis.
so you were 58 or 59 years old and immediately
50,
got
59, yeah.
slammed with the news that you have bony mets everywhere.
Yep.
Do you have any family history of prostate cancer?
No family history, and I just got results of the color study, and
Oh,
so there's no indication of any hereditary markers.
okay.
Yeah, I'm
And
also getting results from the City of Hope heredity program. I forget what they call it, but
from a
um,
biopsy?
no, this is actually a separate study that they're doing around genetics of cancer.
Oh,
Um,
okay.
then I've also had genetic testing from the biopsy.
And what did that look like?
I don't have BRCA. I've discussed it with the nurse practitioner. So I'm working at this point. When I went castrate resistant, I engaged City of Hope and started
Yep.
working with Tanya Dorf,
Okay, we like
Dr.
her.
Dorf. Yeah, she's great. And actually, I think originally I got the recommendation from this group, and then my local medical oncologist, recommended that I engage her also, because it was starting to kind of get beyond his general oncology knowledge, I think. So
You need somebody like Dr. Dorf at this stage,
yeah,
right?
yeah, and very happy to have done that. So I mean, just to kind of cut the story as short as I can. I went castrate resistant. So I did triple therapy. I started on bicalutamide, followed on by Eligard, and then went right into Taxotere and Nubeca. I tolerated chemo okay. It wore me down pretty good. I never got to what I would consider to be um, I got down to 0.18 PSA, which my
Good.
med onc
Wow.
was very happy with.
Yeah.
Getting down to 0.18. He didn't think I'd get down below 10.
From
Um,
1,000. Yeah.
yeah, from 1400.
Oh,
And
that's
I would have liked to have seen it lower, but
Mm.
and I think I lasted about 4 to 5 months before it started heading back up. And at this point, I'm at 20. So clearly castrate resistant. I just completed with City of Hope a round of my third round of Provenge,
oh,
and which was, everybody says it's pretty easy. I found it to be somewhat difficult. I've still got some blood clots in my arms that may or may not be, but I think are related to Provenge, and that were pretty painful. And I will be starting Pluvicto in September.
okay.
Okay.
Go ahead, Rick. Was that you?
Yeah, it was me. When did you just get sequenced?
The sequencing that was done off of my biopsy was done off of my original biopsy,
Right.
which was from March. I did not get a new biopsy, and Gleason 9, 5+4.
Okay. And so the sequencing. So you were diagnosed in March of 23. So was that the tissue used to
Yes.
do the sequencing? Okay. You have to. You don't have to do anything.
Yeah.
If it were me, I would talk to Dr. Dorf and ask her that you need up-to-date sequencing before you start the Pluvicto.
Okay.
before you start the Pluvicto. The reason being that, especially in a case like yours, there are certain driver mutations that we're now seeing from evidence, smaller studies, but we're working to get the bigger studies done, interfere with the Pluvicto.
Right.
And
Okay.
the last thing we want to happen to you, and we've seen it happen to other guys, is you spend 6 treatments, 6 weeks apart, and it doesn't work, because that's 36 weeks when you could have been doing something else. Now, I mean, I know Dr. Tanya is aware of this, but it doesn't work if we're taking the biopsy from March 23, because all of the treatment you've had since then could have resulted in other mutations that would show up now. And with your blood, with your PSA at 20, we can do it off of your blood. All we need is a liquid sample, and I would send that to Tempus or to Boston Gene, Caris or FMI, but probably my first choice would be Tempus or Boston Gene right now, because I think they have the best tests with the most up-to-date results. And it's really, really important. And the docs aren't doing it. Let me just say that what we've been pushing with a couple of these diagnostic companies is for them to consider a complementary with an E, complementary diagnostic test to go with Pluvicto. We'd like to see Pluvicto, you required to do this test so that guys that have RB1, P10, TP53, certain other mutations, they don't spin their wheels doing the Pluvicto.
Right. So Dr. Dorf did request an updated PSMA PET scan, which I completed. And I continue to light up like a Christmas tree from from looking at the results.
Mm-hmm.
But I hear what you're saying, and even I guess that she's assuming at this point that that's enough, that as long as I've got the PSMA marker, but this testing does more than that.
Yes.
Okay.
The problem
Yep.
is we've seen guys light up and then they
Yeah.
don't do well. They just don't do well. And we lost a guy 2 weeks ago in this situation.
Right.
And he went through the Pluvicto, and then he insisted, and he went through an alpha proton thing. But he carried two of these tumor growth suppressor mutations. And if he would have known that ahead of time, he could have counseled with his doc and said, well, do you really think I should be doing this? And
Right.
I think that we have to be looking for these tumor growth suppressors before anybody takes. Now, there are other mutations that supposedly enhance Pluvicto, like ATM. So if you had ATM, and BRCA may help, but we're not sure. We're talking about somatic at this point, or germline. But we just think it's so important before you start Pluvicto. And one of the things is with younger gents, we see these tumor growth suppressor mutations more regularly.
Interesting. Okay.
What do you don't recall what showed up on your 23 March 20? Well, the first sequencing you had, or do you?
I don't have it in front of me.
Okay.
And yeah, and honestly, it's very difficult to read for me. And even
Yeah.
the nurse practitioner for Dr. Dorf said, yeah, Dr. Dorf has to look at this.
Well, you could send
It's
it to us. I mean, we can take a
okay.
look at it. But more to the point, refer Dr. Dorf to the studies to the studies from ASCO 24. I mean, there were a couple of studies at ASCO 24, and one either just before or just after. I think there's now 3 studies. that are really fingering the mutations that either suppress or promote the effectiveness of Pluvicto. And they're small. And she may say, well, it's not good enough evidence. They
Yeah.
are. But what we're trying to do is we're trying to get either FMI or Tempus to go through their extensive databases and do the analysis so that we have more reliable results. But we feel quite strongly that you really got to know if you're carrying any of those tumor suppressor growth before you start. Otherwise, tumor growth suppressors. Len, do you want to say anything about that?
Um, I wasn't sure. Maybe I missed it, Rick, but I know you told Keith that in addition to the PSMA scan, he should have a second scan, in which case I fully endorse that, like an FDG scan.
Oh
That's
no,
something
I didn't.
okay, you could specifically mention that to Tanya Dorf, because in Australia, where this drug was kind of pioneered, really, uh, they will not give Pluvicto to patients who have some PSMA positive lesions, but other lesions that are PSMA negative, and usually they're picked up with a scan called FDG. Dr. Dorf will certainly be familiar with that.
Yep.
So you could, something Rick mentioned before, but you could be wasting your time with a therapy that's not going to work. So if you have PSMA negative lesions in addition to the positive ones, Pluvicto's not really going to do much. It'll make you weak. It'll make you anemic. It'll have a lot of side effects, but
Right. Yeah.
you know, that's not the point here.
And that was FDG.
Yeah,
Yeah.
FDG,
Yep.
fluorodeoxyglucose, but just FDG is good enough.
Yep.
She'll know
FTG.
that.
Yep.
But let me explain, because if you understand it, it's easier for you to talk to Dr. Dorf.
Yep.
The FDG scan is going to pick up any place it thinks it sees a lesion. And when you overlay the PSMA over the FDG, if we see spots that are what could be lesions, but they don't show up on the PSMA scan, then it gives us concern, because even if we got rid of every place where you were expressing PSMA, we would still have to deal with these lesions.
Right. That makes
Are
sense.
you following us, Keith?
Yes. Yeah. Absolutely.
And that's why we always tell our guy, I forgot, that's why I have Len here.
No. Yeah.
We we always tell our guys, make sure that you do the comparative scan,
That
because a
makes
lot of
sense.
the docs
Yep.
don't bother doing it, and their attitude is, well, we'll get what we can. Well, yeah, that's all fine, except that then we've got to start dealing with the other stuff, and maybe we should have used an alternative treatment in the first place.
Right.
If you're not congruent, if there's no congruency.
Right. Yes.
Thanks, Len.
How's your social situation, Keith? Social supports, children, spouses, your mood, and your friends, all the stuff that we use to help us get through.
Yeah. I am married. I don't have any kids. And my wife is retired also, and I retired at 60.
Oh,
I was planning on retiring at 60 anyway,
oh,
but things were supposed to be a little better than this.
yep,
Yeah,
yep.
but
That's how we all feel.
that's the way it goes, right? So I have a small group of friends that are supportive, and my wife's incredibly supportive. She's a saint.
So
Great.
we have some other groups that may be helpful for you, and you probably know because you've been listening to the.
Yep.
But
The
I'll just
recordings. Yep.
say them. We have an under 60 group, which you're very welcome to attend. And it's really for guys who are a little younger who have issues that the old fogies in this room don't face up to. We have a care partners group, which is a terrific group that your wife is more than welcome to attend, that meets twice a month. We have a Men Speaking Freely group that will be meeting on Thursday this week that meets twice a month. It's either moderated by Dr. John and David Muslin or Rich Jackson. It's Rich Jackson's turn this week. We talk about everything and anything except treatment. So if you start talking about your darolutamide or your PSMA scan, you'll get shot down. But you want to talk about talk about the Dodgers or something like that. That's just fine. Okay, we're happy to talk about things like that. We have a veterans group, but are you a vet?
No, I'm not.
No. So we have a veterans group, but I think that the Men Speaking Freely, the care partners, and the under 60 are probably, I'll check your registration and make sure you're getting reminders for those.
Okay.
And we're here, and I'm so glad you plucked up the courage to get on here. The other thing I wanted to mention to you is if you're not planning on going, think about going to PCRI.
Right.
Okay.
I'm certainly familiar with PCRI, and I understand they're having their event in LA, which is very close, right?
Which is
In
not
September.
far. It's
Right,
not
yeah, not
far.
far
I
at all.
know that. I
Yep.
know the territory and 101 and the 405. I know exactly where you are. It's going to be, start early and you
Yep.
might get through. Dr. Dorff, I think, is a speaker. I think
Probably,
I'd have
yeah,
to look,
right.
but I've got a feeling that she is speaking. If not, Elizabeth Heath is definitely speaking, and she's great. But we'd love to see you. Let us know. We're going to have an AnCan table, and on the Friday night, we're all going to dinner at the Greek restaurant up the street in honor of Dr. E. So, I hope some of you guys will think about attending because it is a very good conference. It's the largest patient-centric conference for prostate cancer, guys. And most people who go find it very worthwhile. So. And we're going to have a very special guest at our table. I'm not at liberty to disclose who the guest is, but we will have, and it won't be the man junk contraption this year, but we are going to have a very special guest.
I will say that I identified PCRI first and watched a lot of their stuff, and I was very happy to find this group because it is very focused on advanced. And emotionally, it's difficult sometimes to listen to all of the videos for those people who have a lower Gleason score or are in a much better situation. So I'm this group seems to fit me well from what I've heard so far. So thank you.
Good. That's
I'll
exactly
just
why
say,
Rick,
go ahead,
go
John.
ahead. I was
I'll
just going to say
just,
that's exactly why Rick designed it this way.
yeah,
So we would
and
feel comfortable with each other, and so those guys won't get scared by listening to us.
Exactly. Yeah, because there's no
notwithstanding,
purpose in scaring the people who don't need this kind of treatment. Yeah, absolutely.
And notwithstanding, John, I would probably say the highest level of anxiety in all of our groups across the board is in the early low risk active surveillance group. It is, it's scary.
Yeah.
I mean, that's just a fact. And that's
I
again
really
why we
noticed that
separate
too.
those guys out.
Well,
Jim? Nope. Okay. Anything else, Keith, that you want that you?
no, I think that's. I don't really have any probably hard questions at this point. I appreciate the advice on Pluvicto. I certainly understand that it's going to be a road, and I think that certainly this is some content I can take back to Dr. Dorf and see how she
Yes.
responds to it.
All right. Well, welcome to group, and hopefully we'll see you in the future.
Thank
And
you.
as you already, well, actually you don't know because it's not on the tapes, but at the beginning of each group, we go through the members and see who has something they'd like to bring up that night so that the group moderator can organize things.
Right.
Okay.
John,
Yeah.
one more thing. Keith, going vegetarian or vegan can extend one's life when one has cancer, right? Some people have been able to live with Gleason 9 and reverse their cancer by changing their diet completely. I'm not saying it's going to do it for you, but it's something you might want to look into.
Is there any advice? So I have eliminated all meats other than fish. So I've gone pescatarian and lacto-ovo pescatarian, if you will. So eggs, cheese. Is there any indication of the extremeness of vegan versus kind of an in-between approach?
One thing we do know is that just what Jeff said, that if you go all the way to vegan, the outcomes are good, better
Yeah.
in general. But if you go halfway to vegan like you're doing, you will do, you, at least statistically speaking, like Jeff says, we don't know in any individual case, but
Right.
you may very well have a better outcome. If there's one thing on that list you just gave us of what you do eat that you might want to watch, it might be the cheese because of all the saturated fat. And you might also watch out a little bit for cutting down on your sugar.
Right. And then alternatively on there was an earlier conversation on exercise, and I was really on the exercise bandwagon a year ago. I was walking 5K every day, although not doing the resistance weight training, and primarily because the resistance weight training worries me with the bone mets and the bone weakness. I am doing Zometa infusions on a monthly basis to try to maintain bone health.
Yeah.
But I have lost the ability or have lost the will to walk because it hurts so damn much for me right now. So
Keith,
yeah.
a couple of things. Did you say monthly Zometa?
I'm on Zometa for bone health. I'm doing
Right.
a monthly Zometa bone health
Okay. Well,
infusion.
that's really old school. I mean, monthly Zometa. I'm surprised Dr. Dorf is using that. I mean, we've basically gone to quarterly Zometa at this point. If you're on Zometa, monthly Zometa is overkill.
Okay, that's good
So
to know.
yeah,
And by the way, it's not Dr. Dorf who did that. It was my original oncologist, and we just haven't, we haven't looked at altering that. So
yeah. Well, Len will
yeah,
talk to you about that in a second. And you're probably better off with denosumab or Prolia than you are, and definitely talk to Dr. Dorf and have her put you on her whatever she likes best for a
our
strengthening. But
program.
you don't want to be on monthly Zometa. It's too much, and it's going to give you problems in the long run.
Good to know.
I mean, that's what we were doing 10 years ago, Len.
Yeah, with Jake. Jake was getting monthly
Remember
injections.
that? Yeah.
Yeah.
Here's a
So
graph of, you can see on this graph that that the two survival curves for fractures do separate, and the better curve on that is denosumab, just like Rick
Right.
just said.
yeah. And if you do prefer to stay on Zometa, then probably you're good 6 months. It's got an awfully long half-life, a really, really long half-life, and we now know that it's that quarterly is as good, and there's research to back that up now. Quarterly is as good as monthly. I mean, this is typical of a sort of a general med onc who doesn't practice and has been using monthly forever and a day, and that's what happens.
Yeah, and his preference was actually something else, and I don't remember what that something else was, an injection versus an infusion, and it strangely enough got refused by my insurance. Nothing else has been refused in my insurance except for this
Yeah.
bone health injection.
Yeah, it would have been probably Zofigo or denosumab that
Yeah,
he wanted.
yeah,
Now people are using Prolia, and you can appeal that with the insurance, and
yeah. We tried and it actually failed.
oh
Um,
wow, okay.
took it to the end. Um, yeah, which was very strange. But yeah,
Uh,
because they didn't flinch at Provenge. So that
yeah.
seems extremely just strange to me that they would be concerned about this.
Dennis, you have a comment, and then after you finish that, why don't you just go ahead and bring up what you were going to bring up tonight?
Okay. Keith, have you done a DEXA scan?
Yes, and it came back normal.
Oh, well, that might help overcome some of the pain just in your head anyway, where you can,
Yeah,
your bones are ready to break
right.
if they're normal. So you might have a lot of mets, but they could be very small ones and not, just in the right place where they're going to give you some pain, but not weaken the bone or have that behind you.
Just one thing before Dennis starts, but it just really for our own information. I'm guessing with a PSA of 1400 plus
40.
that you
Yeah.
weren't testing your PSA regularly.
I actually had a 2-year previous PSA of 4.
Wow.
Whoa.
Yeah.
Wow.
That's what I thought. Wow. So it
Yeah.
went in 2 years. It went from 4 to 1,440.
Was there anything in that period that was unique to you at that time?
Um, I mean, in my life, my house
Right.
burned down. Um,
Oh.
one of those California wildfires took out my house.
So you
So
had a lot of stress with that.
yeah, a fair bit. Yeah.
Which canyon were you in, Keith?
Uh, we were on the Thomas fire, which at the time was the biggest fire, the one that caused Montecito mudslides, and
Yep.
we were on the first night of the Thomas
Oh,
fire.
oh boy. So sorry.
Thank you. Well, it all ended up fine. I'm in a beautiful new home, um, mostly due to my wife's incredibly hard work and engaging an architect within 24 hours of it finding out it burned down.
Dr. Jeff, and then we're going to go to Dennis's issue.
Yeah, I just want to ask, you said you're in a lot of pain when you try to walk now. Where are you having pain?
Mostly my left leg, kind of from my hip down halfway down my leg, my back, my lower back, where the PSMA PET scan indicates I have a fully involved um, uh, spine bone, and my left side, my right side, I'm sorry, my left leg, my right side.
Have you tried stationary bike, one of these incline bikes instead of the pressure of walking?
I once again, once I kind of lost the walking, I lost the will. So I need to figure out what can work for me. And that's a great idea. I mean, that's, yeah. And
And
the the concept of what you were talking about earlier tonight, or the group was talking about, around having cancer expert people who can help with resistance exercise, that's been one of the real things that I want, because I feel like if I go, I've never been a weight trainer, weightlifter, but if I go to a gym and I just engage, any trainer, um, and I know that I would probably want to have a trainer, that they're going to hurt me.
Yeah.
Yeah.
Um,
So Keith,
Yeah.
use that link that I put in the chat window earlier on,
I
and
grabbed it.
find
Yes.
a list of ACSM trainers, or John had another group, but I know the ACSM trainers are good, and find an ACSM trainer that's in, that's in Ventura County, and see if you can, or Santa Barbara County or whatever, and
Yeah.
see
Right.
if you can work with them, because they are good, they are properly trained, they understand hormone therapy, they'll understand the issues around your bones, and I think that's worthwhile. The other thing is also to reiterate what Dr. Jeff said. Check out the integrative facilities at City of Hope, and
Right.
also ask Dr. Tanya if there's any special exercise programs. They may have some trials going on right now. So
Okay.
check all the exercise out when you see her next. I'm hoping if she is at PCRI that I'll get to talk to her a little bit.
Great.
Keith,
Okay.
I have one other question to ask. Somebody asked, is there anything unusual or lifestyle? I had a MRI of a PIRAT of 2, and 2 years later, I had an MRI with a PIRAT of 5. And when they asked me the question, then my biopsy was a Gleason 9. Two things happened to me in those 2 years. Number one, I was taking Proscar every day for
Mm.
BPH. So I don't know if you were taking Proscar, finasteride. And the other
Nope.
thing was I had multiple COVID injections. Those are the
Mm.
only two variables in my life that happened to go from a PIRAT of 2 to a PIRAT of 5 in that 2 year period.
Well, I am COVID protected. So yeah, that's an interesting one. Yeah.
Jeff, you forgot to mention your 6 months on the International Space Station being exposed to cosmic rays all that time. Dennis, would you take over, please?
Yes. Okay. Thank you. Uh, this is a tough one to follow. We wish you the best, Keith. And one last comment I had on your situation.
Thank
You
you.
said one of your vertebrae, I guess, was fully involved. I'm not sure what that means, but it sounds like it's a pretty good sized tumor. One of the other concerns I did hear mentioned was spinal cord compression. And I think a neurologist or whoever would be the best medical expert to evaluate that before you start with weights or anything that's going to involve that lower back. We've had an individual in the past in this group that we lost due to spinal cord compression, at least one that I know of. So
Very
that's one
good.
that I had for you.
Yep, good
Uh,
point.
my situation is I just come off my approximately 1 year drug holiday, second time around for me. And the PSA, we waited till the PSA got to 2, had no problem with that. I'm feeling fine. The year was good. I could build up a little more muscle, I think, off of the hormone therapy and so forth. But the results were, I had a number of new bone mets, spinal, all the way on up to T12 uh, from the sacrum, another one in the sacrum. I guess the sacrum is actually two parts because I had had the sacrum radiated before. I think it was part of it because I got another, and that was with this BRT. But I've got a new one in the sacrum on the right side. Uh, and then I've had increase in the SUV on two others, one more L1, and then my right femoral neck. This is one that's been around for a while, so that one is up to 11.6, and the T12 was 13.7. The others were less than 10. Then I had a lot of uptake in lymph nodes from the para-aortic to internal iliac chain lymph nodes. Most of those are all under 10. And I had mediastinum, right perihelial mediastinum. That was also low, less than 10. And then the increase in some of the existing ones that I've had before. This was a comparison. When I said existing, it's comparison with the previous PSMA PET I had. And then that, let's see, those are some of the highest ones that I have. Left superior mediastinum prevascular area, that's up to 17.8. The right precardinal node, 15.9, and then another one in the paraesophageal. It rose, but not by very much. That's less than 10. And the treatment plan is, according to Dr. Singh, being that I was still responsive to the hormone therapy, still sensitive to hormone therapy. So we're going to pick up and continue with Eligard. And I'm going to, before that, we're going to start with Nubeqa. And I've gotten that. He's worked with my local oncologist down here in Tucson. So we're going to start with Nubeqa at basically the half dose. And just to get started to see how I do with it, make sure I'm having any issues with it. And then within a week or so, we will start the Eligard. That's the plan. First injection to restart that. And let's see. Oh yeah, then next week after that, I'm due for another Prolia, 6-month Prolia injection. And then in September, another lab, and then a follow-up visit with my local doc to see where everything is going. And that's where I'm at. I'm happy with that we've got it identified. You know, you always get apprehensive when you start getting close to the point where you're going to start up again.
Yeah.
But it looks a good news. There was nothing showed up in my prostate that we had radiated. So that was a very positive thing that I had done.
And the other good news is that you're still hormone sensitive. Want to be grateful for that.
Yeah. Yep. So
Dennis, any reason why you're using Eligard and not Orgovyx?
No, I mean, that's what I've worked with before. It didn't bother me. You know, I don't get any testosterone back. My highest level was like 18 after a year.
Yeah,
So
but you might do if you used Orgovyx. I mean, you know, it's if you can get it, it's a much better drug.
Yeah. Well, I guess we'll see what happens with the Lupron. It's worked for me. The Orgovyx that's a Part D drug, isn't it too?
Yep.
Yeah. That was a big ticket item, and with the Nubeqa could possibly be a big ticket item, at least for a short period of time. You know. But I'll keep it in mind. I know I mentioned the Orgovyx before. I don't know if he's not a big fan of it or if it's my situation that he, you know, didn't think it was warranted, that I would get any better results from it or whatever. But my testosterone has never risen even before.
Do you have any pain?
No.
Okay, that's good.
Yeah.
Dennis, what did you say your T level went up to? What value?
18.
18?
Yeah, it had been at less than 12. the whole time. It's never
Well, I
gone
might
above.
make the case that you are castrate resistant because those are castrate levels of testosterone, even though you're not or you weren't on an ADT drug. The only reason that makes a difference is it might make other therapies available to you once you're castrate resistant. But I guess it doesn't hurt to try the hormonal therapy, see if that does help. But
Yeah, and
you know what I
I
mean?
raised that question, and I said, why am I progressing my PSA and Mets showing up here, um, and I'm at this very low level of testosterone. He says, well, the longer you're on the ADT, the tumors don't need as much testosterone to keep proliferating. Which is, I mean, I think that's the first time I've heard that. So,
Oh, yeah, that's
But no,
true.
it's
Go
true.
ahead.
Yeah. No, you
That's,
go ahead. I was just gonna say it's true.
that's
yeah,
true.
it
Okay.
is true, but it doesn't change the fact that your PSA was rising at T levels that were at castrate levels. So that my point is, you may very well. Have you ever had Provenge?
No.
See, like you could be eligible for Provenge, for instance, if you're castrate resistant. But like I said, go ahead with the hormonal therapy. If there's no PSA response after, let's say, a month, then you might want to talk to your doctor about
That's
therapies
exactly,
for
that's the plan.
MCRPC. Yeah.
That's the
Yeah,
plan.
don't go giving it, 3 to 6 months to see what will happen.
Mhm.
Don't waste any time. If you don't have a nice brisk response to being back on hormones, I think that's the message of what Lynn
A month
says.
from when I start my Eligard again, right? I don't think I'll see anything from the new Becca that fast, or does that work fast too?
It did for me. Within a month, my PSA had dropped quite a bit.
Okay, thank you.
Okay, good point. All set, Dennis?
Yes, thank you.
Did I lose Mark? Has Mark left? I don't see him. And I've
Mark
got
Raglan's?
everyone. No, Mark
Oh, Mark
T.
Thompson. Oh, damn. Yeah, that happened last time he came on as well.
Okay. I'll go on to
John,
David H. then. Yes,
John, can I
Glenn?
just ask a quick question of Keith? Um, you said you had a lot of bone mets, Keith. Did you have lymph nodes lighting up also?
Um, Strangely enough, no lymph nodes, no known soft
Yeah,
tissue involvement.
no
Yeah.
soft tissue, no lymph nodes. So you are actually pretty good candidate for radium.
Remember we had this discussion a year or something ago about radium, Pluvicto, the order of which to go to, which one to choose.
Yeah,
I
yeah,
was thinking if he turns out to have a mutation that doesn't predict a good response to Pluvicto, that we'll have a radium discussion in here.
yeah.
Interesting.
Maybe because there's a theory that all the radionuclides are inhibited by these mutations, John.
Oh, I
That
see. So
it's not.
anything that applies to Pluvicto would apply to radium also?
Well, it's been suggested. I've read that, but we just don't know. We don't have enough research.
Well,
Anybody
anyway,
else?
if you do have that second scan, to see if you have any PSMA negative lesions,
Right.
then if I were you, I'd definitely talk to your doctor about see if radium's appropriate.
Sure. Thanks, Lynn. Thank you, Lynn. And Jeff, I'm going to take your take over for the hot flash person of the group. So
Mr.
Or do
Hot
you have
Flash?
an Ember?
I can
Do you
be
have an
Mr.
Ember
Hot
watch?
Flash.
Do you have an
What's that?
Ember watch? Do you have an Ember watch?
I do not.
You do not. I will do it, or somebody else will do it. See what Jeff is holding up.
Yes, yes.
Okay, so this is a watch. It doesn't work for everybody. Anybody got an Ember watch they want to sell on because it didn't work for them right now? If not, it does work for a lot of guys. You wear it on your wrist, and it intercepts the nerve stimulation to give you a hot flash and cuts it off. And it works for a lot of the gents. Not everybody, but it works for a lot of the gents.
I could
And
send you mine if you give me your address.
well, there you go. Switch addresses with Harry Spieler in the thing and talk to him. But it's for some guys, it's really been great.
Mhm.
Okay, switch addresses with Harry, and some guys it doesn't work. Other guys, they love it.
I'm glad that came up. We missed the hot flashes for you.
Yes. I
Carlos has an extra Ember watch too if Harry doesn't work out.
Okay.
David, what have you got?
All right. Good evening again. So just to catch folks up, I was on one time before. I gave you sort of a overview, just real quick. 65 years old, diagnosed with metastatic cancer about in April with a lesion on my pelvic bone. So where I am, I've been doing the hormone treatment, also dealing with the hot flashes for sure. And I'm getting close to the radiation treatment now. I met with a new radiation oncologist a couple of weeks ago. His name is Tobias Chapman. He's with the Inova Shar Cancer Institute, and I'm in Northern Virginia. I liked him a lot. Harvard background, trained at Johns Hopkins. I think he knows what he's doing. So I'm going to stay with him. I did verify that the hospital where I'll be doing the radiation, which is close to me, has the True Beam technology. Someone from this group had said, "Well, make sure that the where you're going to do the radiation has the best equipment." So he confirmed that's the very best. He said it's as good as Hopkins. You're not going to do any better there. No need to be driving up to Baltimore. So I'll take him at his word on that. And but before I start the radiation, my next big step is I'm going to get uh,
Spacer.
the spacer. Right. So that's scheduled for this Friday. I'm getting all prepped for that. Just one interesting point on that. Maybe you'll have some comments on this. Initially, they asked if I could have my urologist do that, and I told them that, well, I don't really have a urologist that I particularly love. So they like to hear that because they've got an in-house radiation oncologist doctor. They say he is just the specialist in that. And uh, Dr. Chapman said a lot of times urologists don't really know what they're doing when they put the spacer in and what it's for. So that was an interesting point. Again, maybe some of you will have thoughts on that. But right now I'm scheduled to have that done on Friday. I'm getting a few more MRI, CT scan the following week, going on a final vacation to Europe. And then when I come back, I start my radiation treatment, which looks like it will be 27 sessions, or 27 or 28. And because the lesion is right on my pelvic bone. He's telling me that they can pretty easily or effectively irradiate both the prostate and the lesion at the same time, which will help simplify that. So that's where I am right now.
Okay. And have you started on enzalutamide yet?
Yes, yeah,
Yeah.
I have. I've
Okay.
had one injection,
Okay.
and I've been doing the Xtandi for since June. But those are my two main medications right now.
Okay.
You must mean Lupron then. Not
Luperon, yeah. The 3-month injection, yeah.
Eligard, actually, I think you're on, right?
Eligard,
Yeah.
correct.
David, this is Julian.
Yes,
Did you say you're going to space OAR inserted?
I'm sorry, say again?
Are you putting in a space OAR?
The spacer, the gel spacer?
Yes, sir.
Yeah, that's scheduled for Friday.
Okay, great. Because I had that done before they did my radiation, and it helped it quite a bit.
Yeah, they said it's to protect the rectum and
Yes,
other sensitive areas down there. I'm all for that. So hopefully
exactly.
that'll
It's a very simple procedure,
right,
you know, and it goes away after a while. So,
right.
yeah, good thing you're doing it.
Okay, good to know. Thank you.
Any comments, Jeff?
Now, are they having you have fiducial markers inserted before the radiation?
Yes, I think it's a combination, the fiducials and rectal spacer at the same time, and then the simulation to follow. That's the CT scan. So that I think everything that needs to be done. I hope in the next 2 weeks.
Any other questions or comments?
David, did they tell you you're going to need to have a full bladder and an empty colon?
Yeah, that's right. They made that point. They said it's a little tricky to get that combination
Yeah,
worked
yeah, yes,
out.
it's very, very tricky. As soon as they were done, I ran to the bathroom as fast as I could.
Okay,
Thank
I'll
you.
do my best.
Yes.
Larry
Anybody
Fish. Oh, go ahead.
is anybody going through radiation right now that has any words of wisdom for David?
I'm going through, this is my second week, David. I did not get a spacer in. I discussed it with Dr. Nasser, and he indicated he evaluates it as he goes through it. And I'm currently on IMRT, 25 sessions, and then 2 sessions of SBRT after that. Based on this conversation, I'm going to bring it up again with him as he looks at SBRT down the road. But right now I'm on IMRT, and I'm not having any side effects either from hormone therapy or from radiation therapy. But those markers were painful to put in.
Who gets
What are
selected
those
for the
are
spacers
metallic?
and who doesn't?
What
Well,
was
some of that is the philosophy of the radiation oncologist, because some radiation oncologists favor them and some do not, John. Like um, Mac Roach is still against them. I mean, when I went through my treatment, they were still in trial, and so it really wasn't a big issue, and they weren't widely used. That said, he still doesn't use them. Some of them feel that it moves. It can move the glands and the areas, and so you don't get as accurate an aim. I think that's one of the reasons they don't like it. I've never really followed it, and I always say the same thing, and then people pipe up and say, well, these are the disadvantages. I think most radiation oncologists today will use some type of spacer, but some are still opposed. Maybe Mac will talk about it at PCRI.
Hmm.
If not, I'll ask the question for I'll be in the audience. I'll ask the question for him to bring up the pros and cons of spacers. Dr. Jeff.
Yeah, so I've brought this up so many times, but since this is a new guy, I'll bring it up again. The game changer for me on radiation, I had 48 sessions, and it got to the point that when I drank that water, I didn't have problems moving my bowels, but so my colon was empty, but my bladder was full and it was horrible. It was so uncomfortable to hold that until I was introduced to a drug called Gemtesa, and that was a game changer. And I think every guy who's going to undergo radiation should know that Gemtesa is there. It's a muscle H3 blocker in the bladder musculature, and it expands your volume, and all that urgency goes away. So that, as you heard Julian say, he ran into the bathroom after the radiation. Well, so did I. And some guys didn't make it. And so this drug, for me, made it so comfortable that I didn't dread drinking that water and having the treatment. And
Yeah.
and I've said this before, but uh, it's just changed the landscape for me.
Yeah, as a pushback to that, they told me I was drinking too much water, and I had to wait and get rid of some of that. Since then I've never had a problem. So I think it's dependent on the individual. But getting back to the spacer and what Rick indicated, Dr. Nasser indicated sometimes, depending on the individual, some of the lesions or the cancer cells might get underneath the spacer.
Yeah.
And so the radiation is not hitting it. So it depends.
Yeah.
And that's why Dr. Nasser is saying he wants to see the next scan I'm going to do next week before he makes that evaluation.
Yeah.
Uh-huh.
Just one point on the Merbegram, the Gemtesa. Um, it's an expensive drug, so just check with it. And there may be other drugs that are less expensive that do something similar. The suggestion is a great suggestion, Dr. Jeff, but it's just an expensive drug for some people to access.
Right? But it's only 30 days. So
Yeah.
in my case, I paid $5 for a 30 days it was for me it was 30 days, the last 30 days. So I mean, it's 30 days of comfort versus 30
Yeah.
days of uh, feeling like you're going to urinate in your pants every day.
Well, you got to wear the Depends.
Yeah, but I preferred not to, and I preferred to make the toilet.
It depends what you prefer, right, Dan?
There you go. There you go.
Exactly. It
Well,
depends
do it
on
right. I've been really miserable with radiation cystitis this past summer. So do it right. Do what they tell you. Do anything you can to avoid it. It really scares me to see a toilet full of what looks like pure blood, even though I know it's not. Hey, Larry, you got in a little late and I didn't get to check with you. Do you want to bring up anything?
No, John, thank you very much, though.
And same question for Steve. Steve L., are you still there? Okay, he may have stepped away for a little while. we've got some time now. Anybody can bring up anything.
Well, calling on
Len,
Larry made me think of one thing, which is I heard this week that as of October 1st, Chuck Ryan will be accepting patients at Memorial Sloan Kettering. I like Chuck very much. He's a good clinician, and I think it's a great addition to the team at Memorial Sloan Kettering.
good to know.
Yeah, and for those of you who don't know, Chuck Ryan was, when I knew him, he was at UCSF. Then he went to head up the group at University of Minnesota, Masonic in Minneapolis, and subsequently went to PCSF, where he was the CEO for a couple of years. I don't think he and Milken exactly got on, and now he's going to Memorial Sloan Kettering. So, but it must have been nice to take that mega salary for a couple of years, I have to say. I never looked up what Chuck was making. You can find it in the 990. I did look up what Jonathan Simon was making, and it was about $1 million.
Oh, wow.
So
We have a friend who's just finished his radiology. What is it you go through after you finish medical school?
Fellowship or
Fellowship,
residency.
and he's going out to Los Angeles. He's got $450,000 a year to start right out of college. A fellowship at Harvard.
Len?
Yeah, John, I have a question for you and one for Dr. Jeff. For you, John, did you have brachytherapy? Just wondering.
Nope.
Oh, you did? Okay.
Straight IMRT. Old-fashioned 47 sessions.
47?
No spacer. Yeah, 47, 48. I forgot what it was exactly.
Okay. And
Lots of
where was that done?
This was done at Smilo Cancer Center at St. Francis Hospital in Hartford.
Okay. And Jeff, same question. Where did you get your 48 sessions?
In Hartsdale.
Was that part of
Hartsdale?
Part of
Advanced ART, Advanced Radiation Therapist.
Oh, okay. Because I had 48 sessions back in 2016 it was at MSK, and at that time, nobody else was doing that in the whole country. So I'm surprised to hear that you guys who came along afterward still are getting that many sessions.
Yeah, I was pretty much just before the era of hypofractionation.
Yeah.
And I missed something. I missed asking Mr. Tolbert how he enjoyed the Wednesday night session. How was the Wednesday night session? It was a pleasure to meet you, Richard.
Looks like he's searching for his unmute button, Rick.
He is searching for his unmute.
There he goes.
All right. I thought I was unmuted. I'm sorry. No, it was a pleasure meeting the legend, and and meeting some of the other folks that have been on the call here. It was great meeting Dr. E, and I'm very grateful to my friend Richie Johnson for introducing me to AnCan.
Yeah.
What about that? What's that saying? Never meet your heroes.
There you go.
Well, one of my heroes is Richard Talbot's friend Richie Johnson, who is an amazing lady and who is a moderator for us on our renal medullary carcinoma um, support group, which is just a horrible disease. It's just an
Yeah.
awful disease. And one of the pleasures I had was meeting one of the gents from that group, a former Army captain who is doing, except one of the few people who is really doing well. And it was great to meet Andre. He came to the group, and it was just he came to the session on Wednesday night, and that was lovely. So, but yeah, Richie is very special for us.
Yeah, she's a very special lady, gone through a lot, and her foundation is doing great things for people with RMC.
Yeah, 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 yeah. Oh my gosh, look at that. It's quarter to the hour, and we're like, "Oh, well, how did you do that?" Well, I suppose it was a smaller group. We even got through a newbie who came in late. Oh my, I
It's
can't ever remember us doing that.
it's really nice. I looked into this group because this is Ben's group. His loss, he'll probably cover for me in 2 weeks and get 57 people, you know.
Yeah. And four new men. And four new
Yeah.
men. So, yeah. Yeah.
Oh,
Anybody else?
I do have something to ask about,
Yeah.
Larry. Has anybody been getting a lot of, I don't know, text of some kind or YouTube or Facebook from Merck about all of their trials for advanced prostate cancer?
Not me.
No.
All the investigative agents, I didn't know.
Comes up on Facebook all the time.
Yeah, exactly. Does anybody know what they're talking about? Those agents they're looking at, the new uh, combinations of things. Anything interesting there? That's what I'm
Um,
saying.
offhand, without doing some research, I don't. But it might be Keytruda trials where they're trying. They're looking at trials to make the prostate cancer tumor hot because prostate cancer is typically a cold tumor, so it doesn't respond well to immunotherapy.
I
And since Merck makes pembrolizumab, Keytruda. Um, there may be there may be trials out there with various agents to turn a cold tumor into a hot tumor. My guess is it's related to that. That's just my
Yeah, I
guess.
know it was Keytruda plus this or Keytruda plus that
Yeah,
or this and this plus Keytruda arm A, arm B, arm C. I
yeah.
didn't look up those agents. I didn't know if any of them looked interesting to anybody.
I mean, there's been a bunch of trials, and it's a real challenge to the scientific community right now as to how we can turn the prostate tumor into a hot tumor because
Yeah,
prostate cancer is such a big market.
yeah. I mean, these were all, castrate-resistant trials.
Yeah, yeah. So that would be what is would it excuse me what it would be related to.
Yeah, phase two, phase three. No, I understood it was Keytruda related, basically, but I didn't look up or start to investigate any of those other agents.
So for those of you who don't understand what we were just talking about, a cold tumor means that the tumor doesn't attract your own immune system. It doesn't attract T cells. So when you get one of these immunotherapy drugs, which stimulates your immune system and encourages more T cells, it doesn't help if your particular type of tumor doesn't do a good job attracting these T cells. So what we're trying to do is find agents that will make the prostate tumor more attractive to be attacked by the T cells. That in a nutshell. How did I do, docs? We got a couple of docs on there. How did I do?
That's good, and a lot of work is being done on that very topic.
Yeah,
So,
that's where, sorry, John.
yeah,
No, that's where like gives me like some kind of hope for the future. If they start to find, so far Keytruda is only very occasionally that beneficial for any length of time. So I was wondering if they could use Keytruda plus, turning cells hot. Keytruda could become, effective.
I mean, right now, Keytruda has a bucket list approval or bucket approval, not bucket list, bucket approval for people that express MSI high or have a tumor burden fraction over, I think it's 8. It might be 10, but I think it's 8. And if you, no matter what your tumor type, if you have either of those two biomarkers, then your insurance will approve the use. And for some people, that's enough, and for some people, it does work, even with prostate cancer, but nowhere near enough. And
Yeah,
we've had plenty of guys with tumor burdens over 8, and they've gotten nothing out of Pembro or
yeah,
one
it's,
of the.
it's kind of disappointing that they're milking these things but not getting anywhere. That's all I
Well,
was
they
wondering.
will, and it does work in other cancers. It works well in melanoma, for example, and lung cancer, for example. I mean, it does work, but they don't have the radionuclide stuff, which is working well for a lot of our guys.
Yeah. No, I was just curious if some people have looked into that more deeply. Thank you.
okay, gentlemen, it's been a pleasure. Next week's group is going to be on Monday at 8 o'clock Eastern Time. See you
With
then.
with
It's me,
Uh,
right? You
you and
mean or
Len,
you.
Ben? It's me, yeah. Okay.
With
with
you.
Len.
Yes.
Everybody stay home, take the night off.
Good
I'll
night,
break John's
everyone.
record.
All right. Thanks,
All right,
John.
guys. Good night. Thank you, John. Good job.
Thanks all.
Bye.
Good night.
Thank you, everybody.